I didn't believe this until I started looking at the data, but we think drugs make a big effect on opioid consumption, but I'm here to change your mind that this is probably the biggest effect size you can have by changing your prescribing pattern. So I come from Stanford, and I have no relevant disclosures related to this particular talk, and I'm going to focus in on the last part of our objectives, which is minimizing the amount of opioid usage both in patient as well as on discharge. And the opioid epidemic that we've already heard a lot about can in any way be because of our attitude towards how we prescribe drugs, and I'm going to try and show you how we can minimize a lot of this by both in-hospital utilization and discharge. So starting off with in-hospital utilization. So Pervez showed you the slide of an impact study we did when we transferred from the combination drug, opioid plus acetaminophen, to regular acetaminophen and the oxycodone only on request. We reduced opioid consumption by 50% on the first 24 hours and 30% in the next 24 hours. But as the arrow shows you, still 2/3 of women were requesting opioids. So yes, we reduced that percentage, but the majority of women still required opioid. So we made another attempt, accepting that a lot of women are going to be taking medication, opioids. Is there a way of minimizing how much they use? So the first thing is we changed our old order set, which were giving 5 milligrams or 10 milligrams based on a pain score. So just as a show of hands, who does the 5 to 10 milligrams every 4 hours of oxycodone following cesarean delivery? Yes, no, or an opioid equivalent to that? And then do you do it based on your pain score, or do you just give a random amount? Okay, so we used to do pain score 1 to 4, they got 5, and then 5 to 10, they got 10 milligrams opioid. And we did something really simple. We just halved the tablets. We got pharmacy to break the tablets in half for the 5 milligram, and we only offered 5. And then because nurses have to go and assess their patients afterwards to look at an analgesic effect, they could come back an hour later, within the hour, and if the patients wanted the other half of the tablet, they could get it. Okay? So we're not depriving patients on the same amount of opioids they could receive, but we were splitting it so that we first saw their response before giving them more. And very importantly, we added, and if patients desire analgesia, because nurses are charged to treat patients' pain. So there's a lot of pressure on nurses to give analgesics if patients are in pain. They could use that trigger of, yes, the patient's in 7 out of 10 pain, but they have requested not to receive analgesia. So did this make a difference? So after the impact study, we have over 1,000 patients, more than 500 before and afterwards. And what we showed is a 56% reduction in opioid use in the first 48 hours. Okay? So we not only decreased median, we also got smaller ranges and interquartile ranges. And overall, still a majority of patients were using opioids, so we didn't restrict opioid utilization. We reduced that slightly, but the most important thing is we were limiting how much was taken when women were requesting opioid. So in the after group now, we have a median number of 5, so it's 2 half tablets or 5 milligrams, so very, very small amounts of opioid. We did not compromise pain score with this, so the pain scores at rest on average were 2, and at peak pains were around 6. No difference between the two groups, or at least no clinical difference. But we were able to show reduced opioid-related side effects by using less opioids, which has been reflected in the previous speakers' talks, that if you use less opioid, you'll get less opioid-related side effects. Now, it's not strictly true that the only thing we did was change the opioid order set. We implemented an education. This is probably a key component. The nurses were provided a lot of information, but we set a realistic target. I mean, pain 0 is not a realistic target, so pain less than 5 is the target we aim at with minimizing opioid use. We provided nurses a series of reasons why patients may have pain, so they don't overly react to treating pain. So for example, when the patient may mobilize, or when the intrathecal morphine is worn off, that's where peak pain were to occur. And then we advise them when to call us. So if pain is still severe despite analgesia that they're administering, when patients reach a threshold of IV medication, as well as greater than 30 milligrams of oxycodone, or whenever pain is delaying discharge. So we gave them a framework by which they could administer, and the inconsistency and the variation within the nursing staff was a big component to improving the care. So that's our approach at Stanford. So Brian and the Brigham Women's Children's Hospital did a fairly drastic approach, which when he told me, I'm like a little aghast. They essentially stopped administering routine opioids. So they did a similar quality assurance before and after. They, just like us, use intrathecal morphine, scheduled acetaminophen, and NSAIDs. So before they were giving the 5 to 10 every 4 hours, which the majority of you indicated you utilize, to not routinely prescribing that. So what basically would happen then is that they told the patients available, the nurses would then call the physicians to say the patient now wants it, and then they would give it. And when they did then administer it, they did slightly less. The encouragement was to give 5 milligrams every 6 hours and up to only 6 doses. So what have they found? Fairly dramatic reduction. So from 68% of women receiving opioids, it went down to 45%. So it was a very effective strategy to reducing patients requiring opioids. Those that did take opioids still actually used quite a bit, milligram morphine equivalents of 60 versus 53, but it was reduced in the after intervention group. They did not compromise pain score like we showed. You do not, despite using less opioids, you're not creating patients that are going to be in more pain. And they also found similar satisfaction scores and no difference in side effects. So this seemed to be a very effective strategy. So before I move on to outpatient prescription, so this is what I would recommend. Your current status quo is probably not adequate with your order sets in hospital. So you have two approaches. One is you can eliminate the routine, or you can just prescribe less. But either way, you could use a combination of the two approaches that I've just shown you. If you are going to use anything, you have to couple it with educating your nurses and your patients, setting expectations for realistic pain scores, not trying to drive the pain score down to 0, and have an ability where the anesthesiologist, not the obstetrician, is notified for patients that are not doing well in pain and who are escalating their opioid requirements rather than just giving them more opioids. All right, now I want to move to outpatients. Obviously, we are heavily involved in inpatient prescriptions because a lot of them are following our order sets we've come up with, but this is an area we've largely ignored as anesthesiologists, and we've given it to the obstetricians to do. So Brian described this study, the multi-center study, survey study, looking at average prescriptions in several key centers, and what they showed was that on average 40 is dispensed and only half is used by patients, and he showed you that there's no benefit to giving more. Patients do not improve their pain score, satisfaction, and the proportion of refills did not change amongst them. So remember, this is a basis of this. So most hospitals at this point in time were using 40 and patients only using half. This has been looked at other centers, both in Michigan and in Denver, and showed a similar amount of 50% utilization no matter what's prescribed, and similarly unnecessarily high prescriptions. And this study from Northwestern was kind of frightening because it showed you the uncoupling between how patients do following their vaginal delivery or cesarean delivery and what is prescribed. There is absolutely no appreciation for how each patient is doing. So these are patients who are prescribed opioids. So 46% of vaginal deliveries use no morphine in the final day before they were discharged. 27% of vaginal deliveries were discharged with opioids despite having no pain. So no pain and taking no opioids, and yet they were still discharged home with opioids. For cesarean section, it was 19% and 19% of the metrics. And they have a plot of, these are the providers just scattered over all the, in red, cesarean delivery, and in blue dots, the vaginal delivery. And this is the number of tablets. And you can see some outliers prescribing close to 200 tablets, sort of crazy amounts. On average, 200 for vaginal delivery and 300 for cesarean delivery. So there was clearly a culture of prescribing for vaginal delivery and cesarean delivery way in excess of what patients needed or were requiring in the operating room. And this is not limited to Northwestern. This is another study, but if you actually look across the board, obstetricians generally overprescribe. So how they defined overprescription is essentially patients not requiring opioids who are then given opioids. And it was a threefold odds ratio for obstetrics, and you can see where the obstetrics relative to other surgeries is on the higher end of overprescribing. So what can you do about it? The simplest thing you can do, if we've all got electronic medical records, is just set a default. Okay? So if you have a prescription, electronic prescription order set, choose a default and add it. So this is data from the ER facilities in Pennsylvania, and they decided to move away from allowing clinicians to choose it, and they set a default to 10. You could still override the default. And this is the utilization in red after the default was implemented, and blue, no default, the default being 10. And you can see the vast majority, I mean, we essentially are lazy, we'll just click the default. So you artificially can drive down how much is given just by changing your default within your electronic medical records. If you already have a default set, it's likely to be 30 or 40. As I've showed you, in the previous institutions generally use 30 to 40. So all you can do is drive it down. So a Yale-based EMR study where they went from 30 to 12 tablets, and you can see there's their 12 default. And again, you can artificially change your curve of prescription to the lower end by just decreasing your default. So first add a default and then lower your default. What should your default be? No one really knows. The Michigan groups looked into it with the Open Network and recommended a 15 for cesarean delivery. And you may say this is pretty low, 15. Well, actually, it's not crazy because the Johns Hopkins compiled via Delphi method a bunch of stakeholders deciding what's the optimal dose. And for uncomplicated cesarean delivery, say 0 to 10. It's not very helpful, but it's showing you that it's on the lower side. And for cesarean delivery, and again, uncomplicated, because third or fourth degree tears and episiotomies can be painful, they recommend no opioids. So if you're going to choose a default, it's probably around 15 or 10 to 15. And as Brian showed you, it is important to also consider not only the amount, but also the duration that you write your prescription for. And he showed you data for the longer you prescribe, the more likely you are to drive a continued opioid prescription, either at 1 year or 3 years. And a study that tried to look into this from the Department of Defense Medical Center, looking at when prescriptions were refilled, that neither for a woman's health procedure, so not specifically cesarean delivery, was 13 days and when the refill was requested, and the median utilization was 4 days. The argument is it's somewhere between 4 and 13 days being the optimal period. Saying that, the government has decided our optimal period is 3 days with a new act of Congress, with the CARA Act suggesting 3 days for acute management of pain. So if you are going to write an order set, it should likely be 3 days. Clearly, if you write a lot of opioids, patients can stretch that for longer than 3 days, but think carefully about not only your default amount, but how long the prescription is for. Now, I've spent a lot of time talking about a default for everyone. What I don't like about that is that you're treating everyone the same, so one size fits all. So everyone gets put in a category of everyone is getting 15. So the better way of thinking of it is stratifying based on the patient's needs. And I showed you the Northwestern study, that disconnect between what patients are using and their pain score and what they're discharged on. So the next series of slides, I want to show you how you can actually start to individualize care. Pervez showed you this study. This was where patients were followed up every day until they stopped using opioids, stopped using analgesics, and were functionally recovered. But opioid use following cesarean delivery at our institution was a median of 9 days, and for vaginal deliveries, 0. So our culture for vaginal deliveries, we tend not to prescribe. But you can see a huge range. So some women going up to over a month of opioid utilization in this a relatively small cohort. So there's significant variability within the cohort. And if you sort of subdivided this cohort into the majority, the 80% versus the 20 percentile, you can see in pain burden at least, women, the vast majority of women have low pain intensity that rapidly decreases, but you've got this cohort of 20%. So this is the group that really is going to require a different dosing regime. So how can we individualize it? So there's been several approaches to this, and Vanderbilt is very clever in a way of designing the amount that they prescribed based on inpatient use. And what they did is they created a formula from analyzing their data in the first 24 to 48 hours after a cesarean delivery, Based on what patients utilized there, they were then individualized using the formula rather than the standard dosing. So prior to the study, they were giving everyone 30 as their standard prescription. Based on this individualized formulaic approach, it went down on average to 14. So 12 to 16 range, but most patients were receiving half that. And if you prescribe half, patients generally use half. So it's interesting that the number of unused opioids went to 8 versus 15. So it is important to remember that you don't want to prescribe too little, that this end tails out too soon, and patients require refills or are requesting the obstetrician for pain consults. So it's working that balance between reducing it but not below a threshold by which patients run out too soon. But this methodology they used worked very well, and it's implemented in the electronic records that that amount is automatically calculated on what patients need. Another way is forgetting about formulas but just stratifying patients' care. So this is not obstetric data, but I just wanted to give you a nice demonstration of this, following various surgical models. In patients not receiving opioids before they left, they were all prescribed opioids. In those who were not taking tablets, you can see in the figure A, very few people took it, and they just took it on the first day. So there was sort of no need really to prescribe in that setting. In ones taking 1 to 3 tablets on the last day prior to discharge, you can see a lot more utilization. And then in patients greater than 4, similarly, more utilization. So they suggested you either give 0 if patients are not requiring opioids, 15 if they took a few, and 30 if they are requiring more tablets. And utilizing this strategy based on their current one, they estimated they would reduce opioid prescriptions by 40%. This stratified approach was taken on by Brian's group in Brigham. I showed you their impact study of restricting opioids. Well, at the same time, they implemented changes to their prescription after surgery, and similarly gave no tablets if patients were not requiring it, 10 tablets or less for those who were taking, took opioids but were not taking them in the last 24 hours, and 20 tablets for those requiring them at discharge. So again, a stratified approach rather than just a one fixed number to take care of all the patients. And what did they show? They showed a dramatic reduction in how much prescription was happening. So it went from 91% of women being prescribed to 40%. So fairly dramatic just by stratifying it based on what the opioid requirements were in-house, and they significantly reduced the milligram morphine equivalents. The one thing that is important to mention that there was some wiggle room and some consultation with the patients to understand their needs, and the prescription was adjusted slightly given input from the patients. So it wasn't a strictly formulaic stratified approach. And this was based on work that they had done previously with shared decision-making in patients, where they went from normally utilizing 40 tablets down to 20 tablets just by using patients as part of a shared decision-making. And despite using 20 tablets, patients still had tablets remaining, and their refill rate was only 8%. So involving patients in the decision is extremely important. And the education is not just with patients, but it's also with care providers. And I want to show you some really striking data. So the first one is, and was already been mentioned, just how much opioids we use in the US. But in the US and the Americas, that's the amount of opioid consumption. It's estimated we have 5% of the world's population and consume 90% of the opioids. This is the global utilization. So as a nation, we have to take a long, hard look and ask ourselves, why are we utilizing or relying so much on opioids? And for cesarean section, this was an editorial, not great methodology, but they asked 12 countries with thought leaders or key opinion leaders whether or not they used opioids following vaginal delivery or after cesarean delivery. And if you look down the list for vaginal deliveries, we stand in contrast. No one else uses it at all on a regular basis or occasionally. And for cesarean delivery, again, we stand in contrast to a lot of other European countries. And the 12 countries that were surveyed in this informal analysis. So we are definitely an outlier as a nation. And a lot of it has to do with our training and physician education. This is a really interesting report, I thought. It ranked hospitals based on the world ranking of hospitals, or USA Today rankings. I'm not quite sure why Harvard's here. It should be Stanford. And then you can see this is the amount of opioids prescribed, and the better ranked hospitals had a lower prescription than the worst ranked hospitals. This is unranked hospitals. This is unranked DO institutions. Quite interesting. And this blob over here is foreign trained, so clearly the foreign trained are automatically not prescribing. So you can see how sharp this curve is. It's very flat when you break it up into anesthesiologists because we are trained about pain management, but the obstetricians have a very sharp curve, implying that they're not well trained in pain management, and it's leading to overprescription. There was an interesting analysis of obstetric and gynecology residents, and they were looking at quartiles of overuse and try to find factors to explain why certain residents were utilizing it more. And training in the West had an odds ratio of 3-fold more likely to prescribe. And then they had a sentence in the survey about being reprimanded by your attending, and that was a predictor for increased usage. In other words, their prescription was being driven by the attending, the supervisor, telling them what to do. So the truth is, to change the practice of residents who are often prescribing, you have to change consultant behavior or attending behavior. And you can show them this data if you want to change behavior. So this is from ER literature. They broke providers into 4 quartiles, the low provider all the way up to the high provider. And this is their patients and the likelihood to use long-term opioid use. So if you show a provider that, I think you'll easily get them to move from this quartile down to the first quartile. And in fact, places that have instituted written guidelines and educational handouts have shown a significant reduction. So it can be done, and it can be done relatively easy without compromising patient outcome. I mentioned education, and education of the patient is paramount, and what is told the nurses tell the patients before discharge or informational packages is extremely important. We have some recommended script for our nurses, but the key factors of this, so number one is the women have to keep taking their NSAIDs and acetaminophen. They're given it in-house, but the problem is they then go home and they rely more on the opioid prescription, as Brian was saying, and the larger the opioid prescription, the more they'll rely on it. You have to instill the principle that you want to minimize. You only use it if you have to, and to try and reduce each day, to try and use less each day. There must be a number to consult, and I would recommend we're the best people to consult, not the obstetricians, and a mechanism of education about where women need to drop off their unused prescriptions. All right, so at the end of today's talk and when you go home, I know this is an area we haven't delved much in the prescription pattern of our obstetricians, but it's time to get them all around and talk to them. So this is my advice to you, having gone through the literature and my own personal experience. Number one is you have to get involved. Yes, we do inpatient prescribing, but we are completely removed from outpatient prescription. You then want to implement either an individualized strategy using a formula or a stratified approach into choosing which patients should get what. So a 3-tiered stratified approach works very well. Even if you give patients a 0, in other words, they're not taking opioids, the one concern is that patients go from the hospital environment where they're being given a lot of help to a home environment where they're doing a lot more, especially with their kid on their own, walking up flights of stairs, whatever they have to do, and perhaps a prescription that's unfilled that they can use if they need might be a good strategy for the 0 opioid, the 0 prescription group. And then stratify based on what you think is a reasonable. The default, if you're going to choose a default, it should be around 10 to 15. And you really want to limit the usage. If you already have a default, try your best to lower it. So if it's your 30 at your institution, try and default lower it to 20, and obviously limit the utilization, although, like I mentioned, the law is going to limit that for us. And you have to use obstetrician feedback to fuel this, because if you're getting too many refill requests and too many calls to obstetrician, they'll immediately abandon the strategy. So you almost need a closed loop where you will modify it based on what you hear from the obstetricians and their patients. And don't make it their problem dealing with patients who have breakthrough pain or need refills. You need a written policy so that all your physicians are doing this, and patient education information. And I'd recommend that we should be the consultation. We are the pain experts when a patient requires a refill. It shouldn't be automatically filling the script in by the obstetrician. It should be a phone call to the anesthesiologist and then filling a script if it's required. Brian touched on the psychological factors. Beware, they're red flags, and patients who are receiving refills or requiring more opioid use should be evaluated for depression and other psychological factors that can contribute to ongoing utilization. And advise patients on disposal because most are going to keep their medication for their next cesarean delivery. Now, not just because Brian's on the podium, but this is a superb review article that was published in The Lancet, and Brian was an author on it. So if you want to learn more, you're welcome to take that reference down and read it. And we're happy to field questions. We deliberately try to get through the talks quickly, so we had time for the panel to answer questions, discuss, and go from there. Thank you very, very much.
Hi, David Rolodi, SUNY Downstate. I understand that cesarean sections are one of the few operations that's performed on someone who may be completely healthy. Maybe an organ donor would be a similar situation. And I know that that sort of puts pressure on us to really make sure that pain is controlled, because we've got people who don't think that they're sick. But I just wonder if we haven't oversold postoperative analgesia. And I know when we talk about giving intrathecal opioids to our patients, I think we tell them, I think the assumption is, well, you're not going to feel any pain postoperatively. And I think that is unrealistic. And I think that sets up unrealistic expectations. And I wonder if that's not contributing to people requesting opioids because they don't want to have any pain at all.
Yeah, I'm happy to take I did mention the importance of setting expectations both with the nurses and the patients. I think that is absolutely critical, and the idea that you're going to have no pain is just completely unrealistic. There was a study that actually looked at JCO's 3 or less. It was a UK-based study. It was looking also at the NICE recommendations, and despite gold standard, like Pervez mentioned, anesthesia, only 38% of women fulfilled that. It is completely unrealistic to have low pain scores, and I think high pain scores is reasonable to within a certain limit. So you have to decide what works in your institution, but that was the key factor, I think, in the success of our order set change. I don't know what...
Yeah, no, and I would just add to what Brennan said. One of the interesting things is that all of the studies that have looked at reducing opioids, or if you stratify hospitals by how much opioid prescribed, less opioid doesn't equate to increasing patient dissatisfaction or increasing pain scores. The scores tend to be pretty similar as long as you have some background of acetaminophen and NSAIDs.
So there's data from other settings that opioid prescribing is lower for non-Hispanic Black women and men. And so the question is, as we start to roll these strategies out, how do we ensure that our pain care is equitable for vulnerable populations?
I can...
Yeah, no, it's an interesting phenomenon. So if you look at what is the population in the U.S. that has the highest rate of opioid use disorder, it's largely a Caucasian, a white problem, and the rates are lower in African Americans. And one of the hypotheses that's been put forward to explain that is that physicians are less likely to give African Americans opioid analgesics. I think the thing to do is for institutions to have kind of clear policies and guidelines, like what Brendan described Stanford has in place, what we have in place at the Brigham, and to treat all the patients the same according to the guidelines that you've put in place, and to take away the physician's discretion in terms of how they're prescribing.
I think just to piggyback onto what Brian was saying as well, I think there may be some cultural differences as well in these populations in terms of how much help and support they get once they are discharged back into the community, in terms of family size. And also there may even be a genetic component to nociception in these women that makes them more susceptible to having increased pain and analgesic requirements in the postpartum period.
Ruth Lander from Colombia. First of all, thank you for a super panel. I think you did a wonderful job at splitting out the topic. There's a lot published on it. I have a few comments and questions. First of all, it struck me, maybe because I wasn't aware of it, that opioid prescription seems to be, the education about opioid prescription seems to be different in the West Coast. Is that something you presented, Brendan? And my question to you specifically to that is that, having worked in the West Coast, I saw how women who didn't want anything for labor and wanted natural childbirth were probably those who then were the most intolerant of discomfort after cesarean delivery and were the ones taking opioids for pain score of 2. Do you have any thoughts about that? Hold on to that thought. My second question is, we've been talking about C-sections as if it's one procedure, and you've alluded to it, complicated C-section or uncomplicated, but we know that there are patients that have been in labor for 36 hours, 48 hours with an induction of labor, and we're still prescribing the same thing post-cesarean delivery and then sending them home with the same prescription. So as we're fine-tuning our tailoring and our stratification, I do worry, though, that we call C-section, or we put in a basket under the denomination of C-section, very different circumstances that bring them to the OR. So I want to know whether you think we should be thinking about this a little bit more.
So as you know, I'm not a big fan of one-size-fits-all, and I really feel like we need to personalize post-operative pain management. And as you alluded to, everyone's different. We did analysis a few years ago looking at elective and intrapartum C-section. We didn't find much differences, but I agree with you. Generally, they look like they struggle more, at least in the recovery part, if not from pain and analgesic use. But you need some mechanism in place that each situation is viewed differently. And for vaginal deliveries, we think vaginal deliveries are benign procedures relative to C-section, but the data where we were following patients, there's not that much difference in functional recovery and opioid use. There's a weak difference, but it was like 27 days versus 20 days recovery. Both can be painful, so I think you have to individualize both vaginal and C-section delivery. And by looking at opioid consumption and pain score at discharge, it is giving you information, and that's probably a good point to start at. And then your other question was the variations in regional variations. I mean, Brian showed nicely the variations over the US map, and you can see different areas. The survey that I alluded to, obviously methodologically, it depends on who's responding and where they're responding, but clearly there's differences in education or approach to opioid prescription. You think United States is one country, but it's clearly a heterogeneous mix of areas.
Yeah, and I showed some of the data on the regional differences in opioid prescribing after vaginal delivery. Threefold difference between the Northeast and the South, and the West and Midwest being somewhere in between. So clearly there are kind of local, cultural differences in the way opioids are used in different clinical settings.
I'm just going to put Brendan on the spot for a second and give you a scenario. If you had someone who is an anticipated pain problem coming for an elective cesarean delivery, and she says, hey, last year my experience, or 2 years ago, my experience was awful. I had really bad post-operative pain. I need lots of opioids. I'm still taking opioids now. We talk about tailored therapy. Can I ask you what your tailored therapy would be for this woman?
So we did a series of studies of giving patients a choice for their, some of you are aware of the infamous deception choice study. And before that study, I did not believe, when you have the patient who says, oh, my pain needs are extra high, and I didn't take that seriously, and now I'm absolutely convinced that the person who knows the most is the patient, and you need to listen to her, and they were very good in our two-study cohort, so we followed the study up and got exactly the same results. Women who chose higher doses knew they needed more, and despite giving them higher doses, still had more pain. So someone telling you that is a red flag. How you change your analgesic regime, no one knows, but that's in the patients you probably would start introducing gabapentin. I wouldn't give up on gabapentin. You see, the problem with all the studies that Pervez presented, they're fundamentally flawed, that everyone gets the same drug, the same dose versus placebo. And what we are now talking about is the majority of women do well and keep doing that, but focus on those extra and start now studying clonidine in that setting, gabapentin in that setting, ketamine. And that's where you'll see a difference as opposed to giving everyone a drug with a narrow therapeutic index, lots of side effects, etc. So I think I'm thinking that's where we're moving towards. We're going to get away from a drug in everyone and starting to stratify. And
Yeah, thanks, Brendan. I think also there's not enough studies that have looked at the combined use of intrathecal morphine, maybe at a lower dose with some of these other drugs intrathecally and intravenously as well. So I think there's further studies that need to be done to evaluate the combinations of drugs as well.
But this issue of a floor effect is a real one, and I think can lead to a lot of null studies where there may be analgesic benefit. And so refining the population, identifying those at highest risk for post-op pain is probably the path forward.
Hi, Krish Ramachandran from Boston. I haven't been in an OB suite for the last 15 years. It was great because I was sitting with Jill, and she's such a brainy person. I like sitting next to her. But, as I was listening to your talk, I couldn't help think that just 2 weeks back, I was listening to Ed Lowenstein talk at Harvard about his old study, which is the high-dose opioid study. The birth of high-dose opioid study happened in Boston, right? The technique. So we've gone from that being fantastic for patients because they were seeing how these very sick patients were being sustained with these high doses of opioids to now saying this is a terrible idea. And my concern with this huge swing is that even then they didn't have the safety measures to determine whether this intervention was going to be good or bad and where it would pan out. So I really want to hear from you what you think are the safety measures for this big intervention. As we take opioid dosing down post-op, one issue that I picked up on with the people perhaps with less resources is maybe access to rescue medications. I'd just like to hear from you what you think at the organizational level we should be doing to identify safety. And also, I just want to point out the whole picture of safety is better. I mean, your talk is very powerful, Brian, because you're talking about public safety and the amount of medications that are just lying out in people's homes. So I'm not talking about the global safety thing. I'm talking about this intervention and how patients feel 10 years, 20 years, and what our practice might be then.
Yeah, I think it's incredibly important as we introduce these new approaches that decrease opioid prescribing. We have to very carefully track what's happening to pain scores, what's happening to refill rates, what's happening to satisfaction. I think most of the data that we've seen to date shows that you can decrease opioid prescribing in a pretty dramatic way around cesarean delivery without impacting on any of those measures. But clearly, any intervention to decrease opioids has to be coupled with an evaluation of the impact on pain. I mean, and just as an aside, so there are now 26 states in the U.S. where there are laws limiting the size of initial opioid prescriptions, most of them capped at 7 days. We don't really have data in terms of what the impact of those laws are going to be. And I think clearly at the health systems level, we need to think about ways of reevaluating patients if they run out of opioids. And you raised the question of patients that live in remote areas, and it's going to be a real challenge in certain circumstances. So it's an area where more work is needed.
I think that's definitely an issue as well because, for example, having practiced in the UK, almost nobody goes home with opioid medications. It's really, really rare. And I think a reason for that is because of the geographical location to your hospitals and the community follow-up. So all women after discharge are visited at home by a community nurse who examines them, sees them, kind of screens them for depression. So there's all of these kind of things that we just take for granted in the UK, which are actually very difficult to implement on a larger geographical setting. But these are the things and these are the lessons that we need to learn from in an attempt to address this opioid crisis.
Hi, Alexey Oskovich, I'm from Jerusalem. Yeah. My question, you are working in a very developed place and maybe one from the best. How you increase the use of tab block and quadratum lumborum block during the last 3-4 years in your practice? And what happened in US, in other places?
I can tell you about how we implemented it in the UK. There's good evidence to suggest that if you can't have intrathecal morphine for whatever reason, then tap block is a good option B for analgesia. So based on that evidence, we were lucky enough to have a regional anesthesia block team, which is actually a rarity in the UK. But we liaised with our block team, and they were very keen to offer all of our women who were undergoing a cesarean delivery under general anesthesia to have the tap block done either whilst waking the patient up, so it didn't really impact on theatre utilisation or efficiency, because the block was just done while we're waiting for the gases to turn off. And with this, we had great success rates. We had improvements in pain scores and analgesic consumption. So I think a kind of multidisciplinary approach with your OBs and the regional anesthesia team, the nursing staff, just to, first of all, explain why you want to implement this and how this could be of benefit to the patient population and the hospital, is a good place to start.
I mean, in a way, the US is, because it's fees for service, if you did a block in recovery, you can bill for it. So there is a driver to do procedures. I mean, the data that it works after spinal anesthesia and intrathecal morphine is weak. So we only use it for rescue block in patients who are not doing well. And our utilization is very low as a consequence. And then general anesthesia. The problem with general anesthesia is often consent. And if you rush back, I just don't like sticking a needle in someone I haven't consented, even though most people probably would still feel comfortable. There was a survey that 2/3 of UK respondents said they would do a tap block in an asleep patient before they woke up, unconsented. So.
That's a good idea.
I think the other thing to consider is there's emerging evidence. There's a couple of randomized controlled trials which have compared tap block to quadratus lumborum, and quadratus lumborum seems to appear to be better in terms of analgesic outcomes. So that's something to consider with your regional anesthesia team. If they're comfortable doing that approach, then that may actually be beneficial.
How your resident familiar with all these blocks?
So Brendan's the regional anesthesiast.
Yeah, I mean, they all have to rotate through in the US 1 month of regional, but a lot of them are now going to the second month, or at least another 2 weeks. So it's part of so most residents should be familiar with it. The problem is, in institutions that don't do many tap blocks, they don't get the training to do it. It's a relatively easy block to do, and it's a relatively safe block to do, so it's something that's worth trying.
But at the same time, it's quite close to the kidney as well, so I think if you've not had the expertise in doing it, then I think there's probably a little bit of a learning curve before you pick up the probe and the needle.
Can
Last
I be
question,
devil's
yes.
advocate for 30 seconds? We've been talking about the opioid refill being a failure of a system, of a stratified or tailored, patient-driven mechanism to reduce opioid prescription. I was trying to think, what's bad about an opioid refill? And I'm happy to be educated. But I want to balance that in the bigger picture that we have now multiple studies, including Chad Brummett's, published in JAMA, showing that 6% of patients who were opioid naive before surgery are now opioid dependent, to the point where persistent opioid use after surgery is deemed the number one post-surgical complication. It occurs in 6% of patients. In my mind, until I see 6% of patients needing a refill, and even then, you tell me what's bad in a refill. I'm not sure I see why that is considered the failure.
So I think
of a
just
system.
one comment about the rates of persistent use that people are describing. You have to be a little bit careful of the definitions that are being used. When you look at the background rate of opioid use in the US population, more than 1/3 of adults are filling an opioid in a given year. So some of the studies that are describing persistent use are looking at a single fill between 30 days after surgery and 180 days. It may not really represent, I think, what all of us are thinking about when we talk about persistent use. So the magnitude of the risk, I think we have to be a little bit cautious in how we interpret that. I agree with you, a refill is not necessary. I mean, there should probably be some baseline level of refill if we're not over-prescribing. It's just something we need to track because it could be a marker that we're sort of, as the rate starts to escalate in a substantial way, that we're approaching the point where we're under-treating pain.
Yes. Yes. Yeah. So as Brian says, if you have a 0% refill rate, you're prescribing way too much. You need a certain amount, and what that is, I don't know, 5, 10%. If it's too high, you're going to lose faith with your obstetricians and say, I hate your new policy, I'm getting all these calls. So you've got to walk the line carefully, and it's nothing wrong with a refill, but view that as a red flag. That's that 5%, 10% of patients that are not doing well, and instead of just filling in a script online and letting them go to the pharmacy and collect it and not seeing the patient, they need consultation, education, it's a red flag if ever you have a high risk of ongoing.
Yeah, I think that's an important point. In the U.S., these are Schedule II medications, so you can't just phone CVS and have them get a refill. They need to come back to the hospital, and that imposes some burden on a new mother. Yeah, with electronic prescribing, some of that may change, but I think in most care settings.
But some prescribe with the ability for one more refill already built into it, and it's probably a mistake.
Yeah, I think.
There's a perception, and it also gets magnified in the minds of obstetricians. They get 2 calls within the month of you changing whatever, and they're like, but you have to track it for sure. And like I say, if you get too aggressive and your refill rate increases too much, you're going to lose the support of the key players.
Yeah, and it probably reflects some undertreated pain at that point too, right?
We're overrun by 5 minutes. I'm not sure if there's another session, but we better wrap it up. And
all right, thanks
very
everyone.
much.
Thank you.